Hello, this is Neander Tabingo from Frontier Nursing University, and this is my SOAP Note presentation for NP 702 Fall 2016. It's titled Bloody Nose. Subjective data. Chief complaint. My nose has been bleeding periodically on the left side and is bright red. HPI. This 73-year-old white female presents in clinic with complaint of spontaneous, moderate, brisk, bright red, painless nosebleed for the last half hour. Has been experiencing small amounts of painless left-sided nosebleed, mostly in the mornings and lasting a few minutes each time once or twice a week for the past 4 weeks. Resolved spontaneously after pinching nostrils. Complaints of some fullness and mild blockage in the left nose. Denies headaches, loose teeth, or deep ear pain. Denies picking on the nose or forceful nose blowing. Currently taking Plavix and ASA for stroke and MI prophylaxis. Denies history of bleeding disorders. Has medical history, MI and CVA 7 months ago, no residual weakness, denies head or neck tumors, bleeding disorders, hemophilia, or liver disease, active medical problems, hypertension. Family history, mother alive, dementia, CVA, father deceased, lung cancer, ETUH abuse, sibling one brother alive, hypertension, COPD, maternal grandmother deceased, CVA, breast cancer, maternal grandfather, diabetes, heart attack, paternal grandmother and grandfather deceased unknown history. Surgical history, hysterectomy 1971, tonsillectomy at 15 years old, no previous nasal or sinus surgery. Social history, drinks half glass of wine with dinner, denies tobacco or illicit drugs, lives with husband and 2 dogs. Allergies, no known allergies. Medications, Plavix 75 milligrams PO daily, 7 months now. ASA 81 milligrams PO daily, 7 months now. Metoprolol 25 milligrams PO BID for 1 year now. Immunizations, flu, October 2016, Pneumovax 2012. Review of systems, HENT, denies head trauma, headaches, facial pain, visual problems, sinus pain, nasal insertion of foreign bodies, loss of smell, feeling of blood dripping down throat. Integumentary, denies EC bruising. Cardiovascular, denies chest pain or pressure, palpitations, dyspnea and exertion, orthopnea, dizziness, fainting, lower extremities edema. Respiratory, denies asthma, shortness of breath, wheezing, hemoptysis, cough, lung disease, or history of bronchitis or pneumonia. Gastrointestinal, denies nausea, hematemesis, abdominal pain, diarrhea, constipation, indigestion, melena, rectal bleeding, hepatitis, or other liver disease. Genitourinary, denies hematuria, vaginal bleeding, or problems. Neuro, denies neurological deficits, seizures, ataxia, headaches, dizziness, forgetfulness. Hematology oncology, denies cancer or other blood disorders. Objective data. General appearance, vital signs, temp 97.2, pulse 89, respirations 22, BP 140/65, O2 sat 97, room air. Height 167 centimeters, weight 60 kilograms. Constitutional, well-developed, well-nourished elderly female, appears stated age and mild distress, alert but slightly agitated, talks in sentences. Physical exam. Skin warm, pink, dry, no rashes, pallor, purpura, petechiae, or telangiectasious. HENT, head, no facial swelling or deformity. Eyes, no conjunctival hemorrhage. Sinuses, no sinus tenderness. Nose, bright red blood left nasal septum, no masses that can be immediately visualized, no septal deviation. Right nose, pink, intact nasal mucosa. Mouth, mucous membranes, gums, tongue, moist, pink, without lesions. Heart, regular rate and rhythm, S1, S2 clear, distinct, no murmurs, no JVD, no edema, strong peripheral pulses. Lungs, clear lung sounds in all fields. Full expansion, no chest wall tenderness. Lymphatics, no cervical node enlargement. The primary diagnosis is epistaxis anterior bleed. Secondary diagnosis is long-term current use of antithrombotics and antiplatelets. This is the most likely etiology due to history of ASA and Plavix use on the site of the bleeding and the Kieselbach plexus in the anterior portion of the nose. The bright red bleeding is arterial, which is more common in the elderly because of mucosal and vascular atrophy, Gurol and Molly, 2014. I acknowledge that there are no other obvious symptoms of GI or GU bleed associated with antiplatelet use, so I will discuss the differential diagnosis later on. Definition. Epistaxis is a Latin term derived from the Greek words epi, meaning above, and staxion, meaning to drip. It is one of the most common ENT emergencies to present to primary care practitioners, Yao, 2015. GARD 2015 defines epistaxis as bleeding from the nostril, nasal cavity, or nasopharynx. It can range from recurrent mild bleed to severe, life-threatening emergency, Sarhan and Algamal, 2015. Etiology. Local causes are facial trauma, local irritation from picking, forceful nose blowing, neoplasia, upper respiratory infection, chronic sinusitis, exposure to irritants, cocaine abuse, allergies, angiomas, nasal steroid sprays, and septal abnormalities. Systemic causes are granulomatous diseases like Wegener's and sarcoidosis, hereditary hemorrhagic telangiectasia, infection, bleeding diathesis, malignant hypertension. Environmental causes are dry indoor environment and lack of humidification, dry winter months with changes in temperature and humidity, and circadian rhythm for epistaxis are common in the morning and late afternoon. Yao, 2015, Gurol and Molly, 2014, GARD, 2015. Medications include NSAIDs, warfarin, clopidogrel, and factor X inhibitors, Yao, 2015. Idiopathic causes, of course, unknown. Pathophysiology. The nasal cavity receives blood from the internal and external carotid systems and is therefore very vascular, GARD 2015. Disruption of the nasal mucosa by trauma, ulceration, bleeding disorders, inflammation, and neoplasms result in epistaxis, Gurol and Molly, 2014. Risk factors are related to etiology and include nose picking, coagulopathy, acute or chronic sinus infections, uncontrolled hypertension, liver disease, alcohol abuse, blunt nose trauma, cocaine use, dry and cold climate, septal deformities, granulomatous diseases, and long-term use of anticoagulants, whole year 2016. Prevalence. About 60% of the population will be affected by epistaxis at some point, GARD 2015. It is the second most common cause at 33% of all emergency ENT admissions after sore throat, Barnes, Spielman, and White 2012, Dynamit Plus 2014. It is common in children 10 years old and below and adults above 50 years old, Dynamit Plus 2014. 90% of nosebleeds occur anteriorly, GARD 2015. Death from epistaxis is rare. In 2005, there were 7 deaths related to epistaxis in the US, and all were aged 75 and older, Barnes, Spielman, and White, 2012. Common symptoms of anterior epistaxis are usually unilateral, continuous moderate bleeding from a group of blood vessels in the anterior septum called the Kieselbach plexus. Most are venous, but arterial source becomes common in advancing age due to mucosal and vascular atrophy. It is the most common site for those taking antiplatelet agents. Anterior bleeds account for 90% of epistaxis incidents, Gurol and Molly, 2014. Posterior epistaxis is intermittent brisk arterial bleeding flowing posteriorly into the pharynx, common in the elderly and those with severe facial trauma, Gurol and Molly, 2014. There could be hemoptysis, nausea and vomiting from swallowing blood, hematemesis, melena from posterior bleed, or anterior bleed with high blood flow. Yao 2015, Hollier 2016, Dynamit Plus 2014. Differential diagnosis. Because epistaxis is a symptom, Hollier 2016, differential diagnoses are based on the etiology. First, I came up with the presence of a tumor that could be out of sight during inspection. A tumor cannot be ruled out considering the unilateral May 2014. The patient's complained of some fullness and mild blockage in the left nose, even without the other symptoms of headache, loose teeth, or deep ear pain could be suspicious for a tumor, Yao 2015. Idiopathic epistaxis is another differential because it represents a majority of the cases, Yao 2015, and because of the apparent source of the bleeding in the anterior left nasal septum, Gurol and Molly 2014. I did not consider ruptured carotid artery aneurysm or traumatic carotid cavernous fistula, as these are severe forms of bleeding that will not probably present in primary care. Immediate treatment, adult epistaxis management. Step 1, protect airway and assess cardiovascular status. Assess for signs of compromise from fluid volume loss. Advise patient to sit and lean forward so blood does not run down the posterior pharynx, and hold emesis basin to catch any bleeding. Have patient pinch nostrils at the bony bridge of the nose. Apply direct pressure to the area for 10 to 15 minutes. Step 2, topical vasoconstriction with oxymetazoline spray or soap, a cotton ball, and oxymetazoline or phenylephrine to press against the bleeding site for 10 to 15 minutes. This facilitates identification of the bleeding site, so step 3 can begin. Step 3 is cautery of the bleeding site. It is done with chemical cautery with silver nitrate or electrocautery, which is usually done in the ER. Procoagulant dressing such as calcium sodium alginate for a patient on antiplatelet therapy is an alternative to cautery. Step 4 is nasal packing when cautery fails. Maricel is one commercial product used for packing. Dynamed Plus 2014, Barnes, Spielman, and White 2012. If anterior packing fails, posterior bleeding is suspected and posterior packing will be needed. This is more complicated and is usually done by an ENT or in the hospital. Medications. In the clinic, vasoconstriction with topical oxymetazoline is the first-line treatment. Topical neosynephrine may also be used, as well as 4% lidocaine. Gurol Molly 2014. Silver nitrate applicators may be used once site is identified. Care should be taken during bilateral cautery, which can lead to septal perforation. Yao 2015. An alternative for patients with antiplatelets, like our patient, would be the use of procoagulant dressing such as calcium sodium alginate. Dynamed Plus 2014. Diagnostics. Gurol and Molly 2014 state that lab studies are ordered on the basis of findings from the history and physical exam. Usually, no lab test will be ordered for epistaxis that is not severe, but the history of Plavix and ASA will warrant checking the hemoglobin and platelet counts. All year 2016. Medication side effects. Oxymetazoline has minor side effects of burning, dryness, stinging inside the nose, sneezing, rhinorrhea, but have the patient report immediately to prescriber if there's angina, tachycardia, passing out, severe headache, or severe nasal irritation. Educate patient about signs of a significant reaction like wheezing, chest tightness, fever, itching, bad cough, blue skin color, seizures, or swelling of face, lips, tongue, or throat. Lexicom 2016. Care should be taken when using silver nitrate applicators for patients with history of nasal surgery or those taking antiplatelet agents for increased risk of further bleeding and septal perforation. Gurol and Molly 2014, Yao 2015. Patient education. Instruct to avoid trauma to mucosa, avoid picking, excessive rubbing, excessive and forceful blowing. Keep septum well coated with vitamin A and D ointment, petrolatum-based zinc oxide or OTC bacitracin ointment until site is healed. Teach home remedy for minor occurrence of bleeding by first spraying Afrin nasal spray to bleeding mare, then packing the site with cotton pledget soaked in Afrin nasal spray and apply to the site for 10 minutes. Consider use of OTC nasal Cs, a calcium alginate-based packing that can be used at home. Explain importance of humidifying the home, partially opening a few windows, and placing water containers near the stove or radiators, and obtaining a humidifier. Consider stool softeners to prevent bearing down that can increase risk of nosebleed. Gurol and Molly, 2014. Consultation or referral, possible tumor to ENT. Recurrent bleeding despite treatment, hematologist, or hospitalization if bleeding is severe. Bleeding not stopped by tamponade can be posterior bleeding and needs to be sent to the hospital right away. Dynamed Plus 2014, Gurol and Molly 2014, Yao 2015. Follow-up. Call the clinic if home treatment fails. Follow up within 24 to 48 hours after nasal packing for anterior epistaxis. Earlier follow-up recommendation is for bleeding, fever, drainage, or increased pain. Consider leaving pack-in for 48 hours if no on anticoagulation medication like warfarin, or if there is high cardiac risk or hemoglobin of less than 9. Irrigate packing with 5 to 10 ml saline and wait 5 to 10 minutes to prevent material from sticking to mucosa before removing the pack. If bleeding not resolved, suspect posterior epistaxis. Remove all packing for posterior epistaxis within 48 to 72 hours to prevent tissue necrosis and infection. Advise the patient to avoid picking or blowing the nose for 1 week and avoid bending or overstraining. Dynamed Plus 2014. Health promotion. Avoid alcohol. Patients with epistaxis were likely to have consumed alcohol within 24 hours of presenting to the clinic or the hospital. Alcohol and clopidogrel go together. Manage hypertension to prevent malignant hypertension, which may predispose to epistaxis, although there is weak evidence in the relationship between hypertension and epistaxis. Prevent upper respiratory infection. Lubricate nares often. Humidify at night and at wintertime. Stop smoking because it dries the nasal passages. Yao 2015, Collier 2016, Sarhan and Algamal 2015. The treatment guideline for epistaxis from the American Academy of Physicians is 11 years old, hence was not referenced here. The Dundee Epistaxis Protocol has steps 1 to 5. The first step being assessment and resuscitation, including airway protection, sitting up, leaning forward, clearing blood from the nose, and assessing cardiovascular status for signs of fluid volume loss or shock. Step 2 is the application of topical vasoconstrictors like oxymetazoline, phenylephrine, tranexamic acid, or lidocaine. Anterior compression is done with a cotton ball soaked in the vasoconstrictor or anesthetic. This facilitates identification of the bleeding site. Step 3, once bleeding site is identified, chemical cautery with silver nitrate or electrocautery is performed. Silver nitrate may be applied in the clinic. Used with caution in the elderly and those on antiplatelet therapy. Procoagulant therapy with calcium sodium alginate would be a better alternative for patients with epistaxis from antiplatelet medication. Step 4 is nasal packing, done when cautery is not effective. Anterior packing may be done in the clinic, but posterior packing is best done by an ENT or in the ER. When anterior packing does not stop the bleeding, a posterior bleed should be suspected. Vascular intervention with embolization is step 5 and is done in the hospital. Barnes, Spielman, and White, 2012. Pharmacologic treatment, Afrin or oxymetazoline 0.05 nasal spray is first line. Spray twice into each nostril. Have the patient pinch nostrils tightly for 10 to 15 minutes. Oxymetazoline spray as sole therapy is reported to resolve epistaxis in 65% of patients in one study. Gelatins, thrombins, hemostatic matrix sealant, or FlowSeal is reported to resolve bleeding in most patients with epistaxis and is more effective than nasal packing. Tranexamic acid soaked pledget may resolve bleeding and reduce risk for rebleed more effectively than anterior packing with epinephrine and lidocaine soaked pledget in patients with idiopathic anterior epistaxis. Procoagulant therapy like calcium sodium alginate nasal packing for patients with anticoagulation or antiplatelet therapy may be more effective and preferred over local treatments such as cautery. Dynamed Plus 2014. Silver nitrate 95% should be used with caution in the elderly or those with epistaxis resulting from antiplatelet therapy. These patients have friable blood vessels. Burrell and Molly 2014. Diet. Hot foods can trigger nosebleed. Yao 2015. Activity. Strenuous activity, bending, straining, nose blowing at all put the patient at risk for recurring nosebleed. Dynamed Plus 2014, Yao 2015. This is my prescription. And these are my references. Thank you for watching.